This presentation will be over semaglutide and diabetic retinopathy, presented by Darius and Adam Mayhaus, PharmD candidates from SIUe School of Pharmacy. Here are the objectives we will be hoping to achieve in the presentation today. Understanding the clinical utility of GLP-1 receptor agonists as it relates to the pathophysiology of type 2 diabetes. Describe similarities and differences in GLP-1 receptor agonist formulations that can impact medication selection. Identify what GLP-1 receptor agonists have an association with increased incidence of diabetic retinopathy, and recognizing what populations are at increased risk of diabetic retinopathy in the use of certain GLP-1s. Here's a patient case. We have DM, who is a 55-year-old white male with a past medical history significant for hypertension, type 2 diabetes, proliferative diabetic retinopathy, and coronary artery disease. His medications include lisinopril, metformin, torvastatin, metoprolol succinate, aspirin, and nitroglycerin. The patient's relevant labs are included on the slide. After patient and provider discussion and examining the patient's prescription insurance drug formulary, the patient will be initiated on semaglutide once-weekly injection of 0.25 milligrams subcutaneously for 4 weeks. Then increase to 0.5 milligrams subcutaneously once weekly for another 4 weeks. Then they may increase to 1 milligram subcutaneously once weekly if additional glycemic control is needed with a target A1C level of less than 7%. After reading this case, do you think that this patient is at an increased risk of developing worsening diabetic retinopathy complications after initiation of once-weekly semaglutide injections according to clinical trial data? Think about this patient case, and we'll come back to it at the end of the presentation. I'll just be doing some background information on diabetes and the GLP-1 drug class. Type 2 diabetes, previously referred to as non-insulin dependent diabetes or adult onset diabetes, is a combination of insulin resistance, reduction in insulin secretion, and inappropriate glucagon secretion. Unlike type 1 diabetes, patients with type 2 do not have an absolute insulin deficiency. Type 2 diabetes accounts for 90 to 95% of all diabetes. GLP-1s, or glucagon-like peptide-1 receptor agonists, are an anti-diabetic drug class that can be used as first-line treatment in combination with metformin for a reduction in cardiovascular risk in patients with type 2 diabetes and ASCVD or high ASCVD risk or chronic kidney disease. They are also used as second line for those whose glucose is uncontrolled while on metformin. As illustrated in the picture shown in the slide, GLP-1, or glucagon-like peptide-1, is an incretin hormone that stimulates insulin release after intake of glucose, slows gastric emptying time, decreases appetite, inhibits inappropriate release of glucagon in the absence of hypoglycemia, and works to promote proliferation of pancreatic beta cells while decreasing apoptosis. The incretin effect of GLP-1 is often diminished or non-existent in type 2 diabetes. Within the recent decade, many GLP-1 receptor agonists have come to the market. These lists on the next couple slides are exhaustive for the currently available products that are FDA approved for type 2 diabetes. Please note that active drug formulations for liraglutide and semaglutide also have FDA indications at higher doses for the use in weight management and obesity. These include liraglutide with the trade name Saxenda and semaglutide, Wegovy, are only FDA approved for the use in weight management. All GLP-1s are administered via subcutaneous injections, except for oral semaglutide, which is trademarked as Rybelsus. Dosing is divided into daily or weekly doses via injection between the different GLP-1s. Lixisenatide once daily and exenatide twice daily work to primarily address postprandial blood glucose via subcutaneous injections. Here we have the rest of the GLP-1s. Victoza, Ozempic, and Trulicity also have an additional indication to reduce the risk of major adverse cardiovascular events, including CV death, non-fatal myocardial infarction, or non-fatal stroke in patients with type 2 diabetes within the adult population and who have established cardiovascular disease or multiple cardiovascular risk factors. The dosing frequency is either daily or weekly injections, as mentioned on the previous slide. Liraglutide is given once daily to affect both fasting and postprandial blood glucoses. Once weekly semaglutide injection, exenatide extended release, and dulaglutide also affect both fasting and postprandial. The GLP-1s have differences between each product in A1C reduction while having a similar side effect profile. GLP-1s that target postprandial states have a reduction in A1C between 0.4 and 0.9%. These include exenatide and lixisenatide. Those that target fasting states lower the A1C by 0.8 to 1.2%, which include liraglutide, weekly exenatide, dulaglutide, and injectable semaglutide. Oral semaglutide has a similar reduction between postprandial and fasting states, resulting in a drop of 0.6 to 1.4%. There is a common side effect profile for the GLP-1s. These commonly include GI irritation like nausea, vomiting, and diarrhea, chance of pancreatitis. Some studies have shown a concern of injection site reactions, but this is not routinely noted in clinical practice unless the patient is utilizing weekly exenatide due to the microsphere technology that is used in the formulation. Due to its mechanisms of action, a positive side effect is noted as weight loss, hence the recent approval of some of the GLP-1s being FDA approved for their use in weight management. The class of GLP-1s, besides lixisenatide and twice-daily exenatide, have a black box warning for an increased risk of thyroid C-cell tumors. The class of medications is contraindicated in those with multiple endocrine neoplasia syndrome type 2, a personal or family history of medullary thyroid cancer, or hypersensitivity to any ingredients. Cases of acute and chronic pancreatitis have been reported with the use of GLP-1s. The class of medications should be avoided in those with acute or chronic pancreatitis. If the patient has a history of acute pancreatitis that has since resolved, the class of medications can still be used with caution. Caution should be used in those with a history of gastroparesis, as GLP-1s slow gastric emptying. Additionally, risk versus benefits should be discussed in patients with irritable bowel disease, as the mechanism of action could worsen symptoms. Contraception is recommended for women of childbearing potential, and alternative anti-diabetic agents should be used in pregnancy. Once weekly, semaglutide is associated with increased rates of retinopathy versus placebo, shown in the SUSTAIN-6 trial, which will be discussed in detail later in the presentation. Additionally, increased rates of diabetic retinopathy were reported in the treatment group versus the placebo group in the STEP 2 trial of once-weekly semaglutide 2.4 mg injection. However, the trial was not designed to perform statistical analysis of adverse events reported to determine the statistical significance of these findings. Dulaglutide 1.5 mg once-weekly injection showed an increased rate of diabetic retinopathy complications versus placebo, with a larger increase in those with baseline diabetic retinopathy versus without, in a cardiovascular outcomes trial in patients with type 2 diabetes.
In the SUSTAIN 1 through 5 and 7 to 10 trials, once-weekly semaglutide injection safety and efficacy was assessed against placebo or active comparator. Active comparators included other GLP-1 RAs, SGLT2 inhibitors, DPP4 inhibitors, or insulin therapy. Notably, all trials in the SUSTAIN program besides SUSTAIN-6 excluded those with known proliferative retinopathy or maculopathy requiring treatment. Additionally, the SUSTAIN 1 through 5 and 7 to 10 trials had an upper limit on baseline A1C ranging from 10 to 10.5%. Reported adverse events of diabetic retinopathy were all mild to moderate, and no statistically significant difference in incidence rate of diabetic retinopathy between treatment groups was reported in the trials. SUSTAIN-6 was a prospective, randomized, double-blind, placebo-controlled, parallel group trial containing 3,297 patients at randomization. The primary outcome for the SUSTAIN-6 trials were the first occurrence of death from cardiovascular-related events, non-fatal MI, including silent or non-fatal stroke. The secondary outcomes were a composite cardiovascular outcome that included death from cardiovascular causes, non-fatal MI, non-fatal stroke, coronary or peripheral revascularization, and hospitalization for unstable angina or heart failure. An additional composite outcome, death from all causes, non-fatal MI or non-fatal stroke, and the components of the composite outcome assessed individually, as well as retinopathy complications and new or worsening nephropathy. This trial did not exclude patients with baseline diabetic retinopathy, nor did it have an upper limit on baseline A1C. Additionally, the patient population had a longer mean duration of diabetes and had a higher percentage of insulin use than the other sustained trials. 3% or 50 participants in the semaglutide arm versus 1.8% or 29 participants in the placebo arm experienced worsening or development of diabetic retinopathy complications with a hazard ratio of 1.76 and a p-value less than 0.05 at 0.02. In post-hoc analyses, no statistically significant differences in incidence rate or worsening of diabetic retinopathy were found in those with no history of diabetic retinopathy with or without use of insulin therapy. Additionally, no difference in incidence rate was found in patients with pre-existing diabetic retinopathy who were not on insulin therapy. When controlling for A1C decreases greater than 1.5% at 16-week follow-up, no difference in incidence rate was found between treatment and placebo. Only those with pre-existing diabetic retinopathy who were on insulin therapy showed an increased incidence of worsening diabetic retinopathy complications. Notably, the sustained trials were not specifically designed to investigate diabetic retinopathy. Baseline severity of diabetic retinopathy was not performed, and there were no routine assessments of visual activity or progression of changes over time. Additionally, long-standing diabetes and insulin use increase the risk of worsening or developing diabetic retinopathy complications, and the sustained 6 trial population had a higher mean duration of diabetes and percent of patients using insulin than other sustained trials. A 2019 meta-analysis of 60 randomized controlled trials of GLP-1 RAs with over 60,000 participants assessed the incidence of diabetic retinopathy and change from baseline urinary albumin to creatinine ratio. The 60 trials were split as follows: 26 with liraglutide, 9 using exenatide, 7 with lixisenatide, 10 with dulaglutide, and 8 using semaglutide. No statistically significant differences were found in the incidence of diabetic retinopathy between GLP-1 RA therapy versus placebo or other anti-diabetic agent, with both confidence intervals crossing 1. However, the study found a statistically significant increased rate of vitreous hemorrhage when compared to placebo, with the confidence interval not crossing 1. The authors mentioned several limitations of the meta-analysis in their discussion. One limitation of the analysis was that most randomized controlled trials excluded patients with baseline proliferative retinopathy or maculopathy requiring treatment, and the data was not always reported separately for those with baseline diabetic retinopathy. Additionally, most trials were not designed to assess diabetic retinopathy, and adverse event reporting was not standardized or formal across all trials. The FOCUS trial is an ongoing trial with once-weekly semaglutide injection versus placebo to evaluate diabetic retinopathy in patients with type 2 diabetes. The trial aims to help fill the gap in knowledge regarding the association between diabetic retinopathy and semaglutide and is expected to complete in 2026. The ADA recommends optimizing glycemic control to decrease the risk or reduce the progression of diabetic retinopathy. The benefits of tight glycemic control have been shown in numerous clinical trials and remains the mainstay of treatment of diabetes to reduce cardiovascular risk and new onset or worsening of microvascular complications. Additionally, the DCCT and UK PDS 33 insulin trials showed long-term benefits of reducing the risk or progression of diabetic retinopathy with tight glycemic control. The ADA recommends an initial dilated comprehensive eye exam upon diagnosis of diabetes, followed by yearly examinations thereafter. If retinopathy is found to progress or become sight-threatening, more frequent monitoring is warranted by the patient's ophthalmologist or optometrist. On the other hand, if A1C is at goal and there is no evidence of retinopathy, examinations every 1 to 2 years are warranted. The ADA and the ACE Comprehensive Type 2 Diabetes Management Algorithm and the once-weekly semaglutide injection prescribing information have no recommendations regarding discontinuing once-weekly semaglutide if worsening retinopathy complications occur, but they do recommend increased monitoring frequency. Patients should engage in discussion with their ophthalmologist or optometrist about examination frequency and diabetic retinopathy complications. An increased incidence rate of diabetic retinopathy complications was seen in the SUSTAIN 6 trial in those with pre-existing diabetic retinopathy while on concurrent insulin therapy, according to a post-hoc analysis. Although no trial is specifically referenced, the dulaglutide prescribing information states that dulaglutide showed an increased rate of diabetic retinopathy in a cardiovascular outcomes trial in patients with type 2 diabetes, as discussed previously in the slideshow. Prior insulin studies showed transient worsening of diabetic retinopathy with rapid and large lowering of A1C, referred to as the early worsening phenomenon. The largest worsening of diabetic retinopathy complications in the previously stated trials occurred in those with pre-existing complications and those with large rapid A1C reductions. These trials support the theory that rapid lowering of A1C may increase the risk of transient worsening of diabetic retinopathy, especially in those with pre-existing retinopathy. If a patient with type 2 diabetes is a candidate for initiation of a GLP-1 RA, the patient's cardiovascular and eye exam history should be evaluated to guide in choosing which GLP-1 RA is best for the patient. When considering semaglutide therapy initiation, certain diabetes experts and organizations suggest using injectable semaglutide in patients with no history of retinopathy or in those with bare or mild non-proliferative diabetic retinopathy. In patients without clinical ASCVD or indicators of high ASCVD risk, the oral formulation is recommended to avoid worsening diabetic retinopathy complications in those with moderate non-proliferative diabetic retinopathy, history of proliferative diabetic retinopathy, history of clinically significant macular edema, or history of diabetic macular edema. Other GLP-1 RAs besides semaglutide should be used in those with severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, clinically significant macular edema, or diabetic macular edema. Dulaglutide should not be considered as an alternative agent when semaglutide is not used due to patient-specific retinopathy history. This patient case is an example of a patient who meets inclusion criteria of the SUSTAIN-6 trial with age over 50, type 2 diabetes, and coronary artery disease. The patient also has a history of proliferative diabetic retinopathy and exclusion criteria of other SUSTAIN trials. This patient is not on insulin therapy, and those started on once-weekly semaglutide with baseline proliferative diabetic retinopathy who are not on insulin therapy did not show an increased incidence rate of worsening diabetic retinopathy complications compared to the placebo arm in a post-hoc analysis of the SUSTAIN-6 trial. However, one could argue that other GLP-1 RAs should be used instead of once-weekly semaglutide to achieve glycemic control and aid in preventing cardiovascular events considering the patient's retinopathy history. Semaglutide, dulaglutide, and liraglutide all have formulations that have been shown to improve cardiovascular outcomes in patients with type 2 diabetes. Liraglutide has not shown an increased incidence rate of transient worsening of diabetic retinopathy complications in clinical trials in patients with type 2 diabetes. Now add insulin therapy onto this patient case. Going back to the SUSTAIN-6 trial and post-hoc analyses, the addition of insulin therapy to this patient case further supports avoiding semaglutide in this patient. Assessing the risk versus benefit for this patient, an alternative GLP-1 RA with data to support a reduction in cardiovascular related events and/or deaths should be used to avoid worsening of diabetic retinopathy complications.
Thank you for listening to our presentation. Please return to the survey to get the link to take the post-survey. Thank you.